She was like, Akitunde, I'll say this in Yoruba, it's not be sweet in English. She said, Akitunde Tori Olorun, ọdún mélòó ló ti lò nínú medicine tó ti ní HIV. I just opened the tap and I kept on squeezing the blood, squeezing the blood. What explanation do I give? How much have I earned from medicine? This is getting my second year of practice. I was thrown aboard, lost in what it could mean for the first time in my life, not just read or hear or talk about HIV, to be experiencing it for the first time.
It was a beautiful thing to see that there are senior colleagues who don't just care about you getting the job done, but about your well-being as a healthcare worker, a fellow healthcare worker.
For the first time, I felt the impact of what it means to be stigmatized. So people shouldn't stigmatize because this person has HIV. I shouldn't touch him. We shouldn't share.
We can't shake.
We can't shake. We can't hug. We can't even. I mean, those basic things. HIV is no longer a death sentence, and I was surprised that the patient actually thought HIV was just like
malaria.
Was just like malaria. The patient just asked me that, hope there's drug that I will take and I will use and I'll be fine.
In the course of performing your duties, you also want to preserve the sense of dignity for that person. So the person doesn't feel like, oh, okay, because it seems like I have maybe symptoms suggestive of an infection, I am now, a threat to your life and all of that.
What do you think becomes the priority if we're trying to rescue a patient in an emergency situation and then a doctor becomes a patient in the process?
So in that case, the doctor who becomes the patient has to be the priority, because if a doctor that is alive that will be able to treat the rest of the other patients. So in that particular case, the priority has to shift.
And finds out that whoever they had whatever with is positive. What should be their next point of action?
Okay, so first of all, the first point of action or the first line of action, calm down.
Hello everyone, nice to be here. My name is Dr. Faramade Mushukwefulowa. And here with me is
Dr. Olonsola Oluwaseun.
I guess well.
All right, my name is Akitunde Omoleke Abisoye, and it's nice to have you here. I want to talk about human immunodeficiency virus, HIV, and common things that the public perhaps do not know. And on this conversation, or with me on this conversation are doctors, we have heard the tale, we have read the tale. However, about a year ago, I lived the tale. About a year ago, I was a medical officer in a private health facility at a hospital somewhere in southwest Nigeria. And on that particular morning, I admitted a patient that presented with complaints of passage of loose watery stool, fever, headache here and there, and a few other symptoms. In the course of the investigation and management of this particular patient, we realized that the patient was HIV positive. I confronted the patient that your test results are out. It shows that you are HIV positive. I remember asking if you were positive. You never mentioned anything like that. And then she obliged. She consented to confess or acknowledge the fact that she was positive. For how long have you been positive? She said she has been positive for close to 5 years. While in the course of managing that patient, of course, in the course of discharging my duties, I sustained a needle prick injury. I sustained a needle prick injury. And at that point, my world turned around. The first thing first, I went to where I was going to wash my hands. I squeezed everything possible out of my hands. I just opened the tap and I kept on squeezing the blood. What explanation do I give? How much have I earned from medicine? This is getting my second year of practice. And my MD walked into the injection room and he asked me, Dr. Moleke, what was wrong? I told him that, sir, I just suffered a needle stick injury from the HIV patient on the ward. And contrary to what I expected him to say, my MD said, don't worry, God will help you. And he started praying for me. Now, I need to make this clear that I'm a man of prayers. I believe so strongly in prayers. And I do not even like to joke about matters around prayer at all, not the slightest inch. However, I felt that in that situation, there was much more that I expected from somebody who was a superior to me than just offering prayers.
Yes.
I tell you the truth, that morning my world turned around. I had read about HIV, I'd known a lot of things about HIV, but I happened to be seeing HIV or be experiencing HIV from a different point of view that morning. I rushed to one of the tertiary centers in the states where I was practicing then, and with the help of a colleague, I was able to get directions as to where I was supposed to get tested for HIV that morning, of course, and then start the post-exposure prophylaxis. The post-exposure prophylaxis is what I was supposed to take that morning. And while the person who was supposed to attend to me that morning was taking my sample, I suddenly realized that there was some set of extra precautions that were being taken that morning. I wondered why. I knew why, and I was thrown aboard, lost in what it could mean to, for the first time in my life, not just read or hear or talk about HIV, to be experiencing it for the first time.
I'm so sorry to hear about your experience. I mean, I know it was quite devastating. While I'll still be going back to the reaction of the lab scientists, I still want us to talk about the fact that this patient in question was earlier diagnosed with HIV about 5 years ago. She was aware and she kept living her life as though nothing happened to her. So I would like to ask, what do you think? What were the reasons she gave as a reason why she was quite nonchalant about the diagnosis?
Well, for the sake of confidentiality, some details will be left out.
Right.
But primarily, one of the things that I think was probably responsible was she didn't even, as at the time, according to the conversation, she didn't even know the point when she became positive,
Okay.
and she had many partners. So she wasn't even sure from whom she got the infection. She wasn't sure how many people she had infected. So I think there was part of lackadaisical attitude and the fact that she probably had this nonchalancy, call it what it is, and that was why she never even bothered. As at the time I was seeing her, she was about 3 to 4 years after having been tested, having known that she was positive before I saw her. So primarily, the only thing I can say was that she was nonchalant. Basically, she was nonchalant.
All right. Thank you. So going back to the lab scientist's reaction regarding how she took extra precautions to ensure that she was not going to get infected by you, knowing fully well that you only had the needle stick injury just a few minutes prior to being tested.
Sorry to interject. My concern that morning was about the fact that I just got tested. I got the prick around 8 a.m. in the morning.
Yes.
I rushed to the health center or the tertiary facility where I got the PEP. Barely about 2 hours, because I remember that day I started the first dose about 11 a.m.
Yeah.
So I knew that the essence of the test that morning was, of course, to know my status
Exactly.
before that accident. It wasn't like she was expecting that this needle stick injury of this morning has transited into. So, but I just realized that, I mean, there were sort of extra cautions that were being taken, and for the first time, I felt the impact of what it means to be stigmatized, call it as it were, because she had to do all of those things. Yeah, I'm trying to balance this with the point of personal protective equipment, but I don't know what would you say the place of that is, because she just kept on using those perceived instruments, and that was all I remember that morning. That was all I remember, because my state of mind was already tampered with. Tell you the truth.
Right.
Yeah, I would like to, first of all, I'm so sorry you had to go through that. I can imagine how you felt actually, and I can imagine how mentally and emotionally destabilized you became, because I also had a similar experience as that, and that was also in the course of performing my duties as a medical doctor as well. So in line with the reaction of the laboratory scientist or practitioner who was supposed to test you for your status, I think generally we have, not I think, generally we have universal standard precautions, right? Whereby we believe that every sample that is being tested for, right, is a potentially infectious one. So we treat it as that. However, there's a place for discretion and a place for professionalism, in the sense that when you're trying to test for a patient sample, especially when you're in the presence of a patient and you're trying to collect the sample and all of that, you know that this is a person who, first of all, has emotions. And at the same time, in the course of performing your duties, you also want to preserve the sense of dignity for that person. So the person doesn't feel like, oh, okay, because it seems like I have maybe symptoms suggestive of an infection, I am now, a threat to your life and all of that. So
And I think to that, I think one of the issues that that we really need to talk about is the matter of stigmatization. Dr. Faramade, do you think that we look at HIV the way we're supposed to look at it? What do you think about stigmatization in the Nigerian context, particularly?
All right, thank you, Dr. Moleke, for that question. So regarding stigmatization with against people living with HIV and AIDS, thank God for the miracle of science. I think it's still currently still is reduced than it was previously. At the time when HIV came about and became publicly known, there was a particular language that we even use in Yoruba culture, Yoruba language that says "Arun ti o gbogun," which simply means that this disease does not have a cure. But I think it's
Or
still
it's
a
not
wrong.
responsive, or
It's not responsive to treatment, which I think is still wrong in the sense that we also have other diseases that don't have cure yet. We have hypertension, diabetes, even epilepsy, that are chronic illnesses. So that language is still not correct. That's one of the reasons why I think could be one of the contributing factors to stigmatization. Then the second reason also is because of the moral attitude of people towards people who test positive HIV. They say that people believe that, oh, this person could have been promiscuous, this person has been sleeping around, so we should not just give them the kind of care they deserve because they were wayward in the first instance. I think the third thing, which is because the disease itself is that it's an infectious one in the sense that it is transmissible from person to person. And because of the time when we didn't have a cure for HIV, I mean, if an HIV patient doesn't take medications and allows the disease to go through its natural course, leading to full-blown AIDS, the impact of the illness itself gets to be seen. The person will lose a lot of weight, would be sick a couple of times and thereabouts. So that's one of the reasons why I think people don't want to get close to them because they don't want to get infected.
And I think Dr. Faramade, speaking about public perception about HIV, I think that people also need to realize, stemming from what you said, that the same way HIV patients have to use drugs every day to ensure that they keep their values at a particular threshold or a minimum to ensure that it doesn't progress to AIDS. I think people need to realize that that's the same thing that happens with patients that have diabetes, they have hypertension. A diabetic patient has to use drug every day.
Exactly.
An hypertensive patient has to use drug every day. The same way HIV patients have to use drugs every day. So sometimes I wonder why the stigmatization is so much pronounced when it comes to HIV. However, I think the other thing that might also be interesting to talk about is the fact that, maybe I'll just ask you that, how exactly do people get infected with HIV? If we talk about the fact that it's infectious and it can be transmitted from one person to another, how does that transmission, how does it happen?
Or
what can amount to infection and what cannot?
All right, thank you. So there are three main methods, or let me say modes of transmissions through which HIV is passed from one person to person. So the first one is through the sexual contact. And this happens when an infected person and the other person engaging in unprotected sexual intercourse. So it could be transmitted through sex. It could be through the male to female. It could also be male to male. Because even when the HIV became known, the people that were even having it the most were those people that were having sex with men having sex with men. So that's that. Then also through the rectal route, vaginal fluids, semen, and the like.
Maybe I should allow Dr. Lawrence to speak on this. People often talk about the fact that you could get HIV from as simple as a kiss. Do you think that is true? Is that correct? That okay, if you kiss somebody that has HIV, your has finished. You have acquired the infection.
So that's the myth actually. HIV is predominantly transmitted via the routes that Dr. Farmadi just highlighted. The routes include blood, seminal fluid or vaginal fluids, breast milk to an extent as well. But predominantly, when there are situations whereby, now, in case of kissing, now, HIV is not transmitted through kissing. No, that one, and no peace. However, there are some kissings that can involve certain kinds of mechanisms that can predispose that can predispose the parties involved, to the infection. Now, because you can find HIV is in blood, right? If two people who are involved in, let's say, the deep kinds of kissing, the French kisses, and all those ones that could either cause cuts or injuries in the mouth, like causing sores, right? So there's already an opening in the person's mouth, right? And then if we have two openings, like in the mouth of the kisser and the kissee, you understand? So, and one of them is positive, they can easily transmit them because it's coming from one portal, one entry, one opening to another. Secondly, is if there are already presence of sores even before the kissing. Maybe there are bleeding gums, there are some canker sores and all of that around the mouth or inside, the around the gums, the tongue, and all of that. And then the person happens to be HIV positive. You understand? So the virus can be transmitted from that route to the other person if the other person also has open sores, yes, or wounds, in their mouth to receive that. So that's the clause.
So it's not transmitted by touch. So people shouldn't stigmatize because this person has HIV. I shouldn't touch him. We shouldn't share plates. We can't shake. We can't hug. We can't even. I mean, those basic things. And I also want to say that from the experience I had, one of the concerns on my heart then was when I got this needle stick injury was how many people do I want to explain to that it was actually from the needle stick injury that I got this infection.
Okay.
God forbid if I had tested positive for HIV. Would I remember that the time when this happened, I communicated with my fiancée whom we're planning our wedding. It was few days to our wedding. And I told her that, babe, I got
needle stick injury.
I got a needle stick injury. When I told my sister, well, for her, maybe because of a level of exposure and maybe for the trust thing, her response or her reaction still surprises me till today. Because she basically just said, no problem, let's hope that it wouldn't come out positive. You've started your drug already. And then I asked that, what about the wedding preparation? Do you think we should hold on a bit? She said, no, we're not holding on a bit, though. We're going to continue what we started. I mean, that was very much reassuring for me. And I remember the reaction of my sister. My sister said, she almost started crying. She was like, Akitunde, I'll say this in Yoruba, it's not be sweet in English. She said, Akitunde Tori Olorun, ọdún mélòó ló ti lò nínú medicine tó ti ní HIV. Meaning that, how many years have you spent as a practitioner that you're already getting needle stick injury from HIV? She was practically crying that morning. And I remember that for the 28 days that I used PEP, maybe I would allow Dr. Lorushola to speak about what PEP means so that people can get educated about what it is and different kind of reactions that can come with it. Sure. But before then, she said, hope you started your drug. I said I started my drug. And I was told to use the drug every day. So my sister kept calling every morning. That was one of the times when I knew that I actually had people who were very, 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 who loved me so much. People who were going to stand by me. And I want to call that out on this platform. She's Opeyemi. She's Arik Atilias. You can check her out on Instagram. She's a fashion brand. She kept on calling me every morning. I was supposed to take the drug by 11:15. She would call me a few minutes to 11. Hope you did not forget your drug. Have you used your drug today? The day I was going to go for testing, she had to call me. Have you gone there? Have they done the test? What's the result? When did they say you should come back? And all of that. So all of that shaped my orientation. And I felt like nobody should get this infection. Not necessarily, not just because it's infectious, but even the level of stigmatization that comes with it. Exactly. And well, I used the PEP. I will talk about some of the reactions that I had. But I just want Dr. Lorushola to tell us say, for example, somebody has had a needle stick injury now. What should be their first point of call? What should be the first thing that they do? if there's an infection, maybe a needle stick injury, or I wouldn't want to assume that somebody would intentionally sleep with somebody who is HIV positive. But if perchance somebody does this Friday night, whatever, and then wakes up on Saturday morning and realizes that and finds out that whoever they had whatever with is positive, what should be their next point of action?
Okay, so first of all, the first point of action or the first line of action, calm down. Calm down. Because really, anxiety doesn't help anybody. It has never helped anybody. It will never help anybody. So calm down. You know, the next thing you should do is to seek help. We have what we call the post-exposure prophylaxis, right? It's a combination of medications, right, that has been formulated to help to treat or prevent infection with HIV by a person who may have been exposed to the infection either through unprotected sexual intercourse with someone who had that, or like in your case and my case.
Blood transfusion,
Hmm.
mother to child transmission.
I really love to hear that your own case, but I want
I'll talk about when I'm done. Mine was very just like yours as well, so but we should talk about it eventually. So, firstly, is to go and get treatment. So usually, what is done is that there's a window period. There's a safe window period whereby it is from the point of contact to at most or maximum of 72 hours or 3 days of exposure. Right. So if a person has been exposed today or right now, okay, they have a 72-hour mercy period or safe window to ensure that they go and seek help and start the post-exposure prophylaxis. And it's what you take once daily for 28 days. And ideally, the person's status will be checked so that you even know that, okay, did I even have this infection in the first place? Just to start with. You understand?
I could imagine somebody who wants to start PEP, who goes to the health facility to start PEP because of exposure to maybe HIV, only to get tested and the person is positive. I mean,
So in that case, you actually start ARVs, you start antiretroviral therapy. But then in a person who now happens to be negative, like in your case, the person will start PEP and would use it for a period of 28 days, and then after that, 6 months after that, there's a repeat HIV test that is being done to actually now confirm the status of the person. So that's about PEP. And then you were talking about some side effects that you were having and all of that.
well, to begin with, before I make a comment on the side effects I experienced, I'd like to talk about the side effects that I am aware of that a particular senior colleague, shared at some point in time, because that also culminated in what amounted to my fear when I was about to start mine. So the person had a needle stick injury, and the person went to get post-exposure prophylaxis, right? And the person had some side effects. The person ended up being admitted in the hospital. And before you say Jack Robinson, the person was already getting dialysis. The person was already being flown out of the country to get medications. The person was fighting life or death, not from the needle stick exposure, from the side effect that comes with post-exposure prophylaxis. Yeah, quite all right. Not to put fear in the mind of our audience, there's a lot of modifications coming on with post-exposure prophylactic medications now. Yeah. Some of them are not with so significant side effects like the ones that people usually use before now. In my own case, that was what culminated into my fear. That was amended to my fear. And when I started the medication, funnily, I still had to be running or taking shifts from the hospital where I got needle stick injury. Pathetically. Unfortunately, rather. Okay, so when I started, the primary side effect that I had was this fatigue, this kind of malaise and headache. The headache was quite disturbing. I had that headache virtually every day. Every day. I had to go to work with that headache. I had to see patients with that headache. I had to sleep and wake up with that headache. I had to carry the burden of, what if after 28 days you end up being positive? What if after 6 months you end up being positive? But that was particularly the side effect that I had then. It was that headache and this malaria or this fatigue kind of thing. That was primarily what I had then. That was primarily what I had then. So I know that this side effects vary from one person, but I'd like you to talk about your own experience and what did it look like?
So first of all, I want to go like just give a summary of what happened that day, that fateful day, and that was about that was about 2 years ago. Now I can laugh about it, but then there was nothing funny about it, and I was doing my house job in a teaching hospital, and I was working that day, that evening at an emergency at the emergency unit there at the hospital. So we had to there was a patient that was rushed in, like around 7 p.m. ish. Patient was rushed in, everybody shouted, "Egbabi, Egbawa, Egbawa, Shanu," and all of that. Apparently, the patient was involved in an accident, had a fracture, so the person's leg was already swollen because blood was already pooling, and the person was bleeding internally. So my partner and I, like my colleague and I, who I was on call with then, so we're trying to see how we could help that person. But unfortunately, there was no lights. There wasn't power supply in the hospital then, and the gen was down and all of that. So we found a way to bring the person into the ER, and then we're trying to set a line for the person just to see how we can see how we could intervene. So in the process, somebody was holding their phone as a light source, another person was trying to set the line for the patient and all of that. And then that was when the assistant, got pricked by the needle that was used to set the line of the patient. So long story short, the way you ran to wash your hands, that's how I ran to the sink. But unfortunately, we didn't even have running water. So you can imagine that I was pressing, and then someone was pouring water on my hand to flush it. But one thing I'm grateful for is the team that was on call, that included wonderful nurses. They were also there too. They joined in pressing my hand too. You know, it was like
And squeezing.
that's that spirit of oneness was beautiful, you know. And then we ran a test for that patient. Eventually, now found that the patient was HIV positive. You know, so fast forward to me meeting our senior residents. Then I contacted our senior resident then, and then we found a way to ensure that I started my PEP the next day after my call, which was a disastrous call. You know, these very busy calls that you don't sleep, you don't get to sleep.
Dr. Onshila, I want you to talk about something. But before then, maybe I want Dr. Family to talk about something, and that is about this Nigerian factor. This Nigerian factor. I don't know if you picked that while she was speaking.
Yes, I did.
They were trying to attend to a patient in the ER. Yeah. There was no lights. There was no running water. No lights, no running water. But before the family does that, Dr. Onshila, what was the perspective of? Because contrary to my own senior colleague when mine has happened, what was the response, or what was the response of your colleague or your
Senior
supervisor when that incident happened?
I was even going to make a comment about that when you said when you mentioned how passive and unnecessarily religious your employer was to your injury. In my case, which was the opposite. In my case, when I told her that, "Ma'am, I had a needle prick injury by a patient last night, and I just found out a patient is IVF positive, that is HIV positive," immediately she said, "Oh my God, where are you?" And so I went to meet her, and then she held my hand, took me to the pharmacy. We contacted the people who are involved in getting the PEP, that's the PEP, we call it PEP, right? We got the person and all of that, and then she ensured that I started it right there and then. And going forward, she followed up with always calling, "How are you? Have you used your medication?" and all of that. So it was a beautiful thing to see that there are senior colleagues who don't just care about you getting the job done, but about your well-being as a healthcare worker, a fellow healthcare worker. So it's a beautiful.
I feel like reiterating that line again, that there are senior colleagues who do not just care about having you get the job done, but about your well-being as a colleague. And I think that's one of the reasons why we have exodus of doctors from Nigeria. Aside from the quote and unquote shege that you see with patients, even the people you're working with, they have, we don't help one another, we don't help each other. Dr. Famade, what do you think becomes the priority if we're trying to rescue a patient in an emergency situation, and then a doctor becomes a patient in the process.
So in that case, the doctor who becomes the patient has to be the priority. Because if it's a patient, it's a doctor that is alive that will be able to treat the rest of the other patients. So in that particular case, the priority has to shift. The doctor has to be well catered for in every aspect. And thank God for the support that you received with your senior resident, who was able to ensure that she was there emotionally to provide support, to make you feel like, okay, you're not going through this alone. We are here to help you, regardless of whatever the outcome was going to be. So I think that's one of the very beautiful things that we need to ensure has to be a culture, even amongst medical doctors. And like, it has to be a very good thing that has to keep happening, or we need to be able to build an environment that will ensure people are able to work and feel like
especially in the Nigerian setting.
Yes.
I mean, I couldn't even have imagined that there's an emergency room where there's no light.
That's very
an emergency room where there's no water. And I think that Nigerians need to understand this. We need to come to terms with the realities that are medical practitioners, not just doctors, even nurses, lab scientists. We need to understand the conditions under which they carry out their duty. Yes, we expect the same level of standard from them as with our international colleagues, but we must also understand that sometimes people are handicapped by the resources they have to work with. Imagine a doctor who has to be using a phone as a light source to attend to patients in emergency. Tell me the fact that even if she didn't have a needle stick injury, if the patient was hepatitis B positive and there were blood stains on the cell phone that she was using to put on lights, I mean, is she also going to wash the cell phone? I don't know if you understand. And then talk about the fact that if you want to wash your hands and there's no clean water, there's no running water. These are some of the conditions under which people practice. All right, so that is a digression. Dr. Faramadi, we've been talking a lot about HIV and our experience. How can we prevent this?
All right.
How can we prevent this? Because even as it pertains to prevention, there's still a lot of things that people do out there. A lot of things that all the name of trying to prevent HIV. So how can we prevent this so-called infectious disease, this big name?
All right. So there are three main ways in which we can prevent HIV. The first one is abstinence. That's the most effective method. Abstaining from sexual intercourse, especially the unprotected one, is one of the very effective methods of not getting the disease itself. Then the B is, we call it the ABCs. A is abstinence, B is be faithful. Like we already mentioned, people that have multiple sexual partners have a higher risk of coming down or getting the virus itself.
What is multiple sexual partner?
All right, so multiple sexual partner, having a multiple sexual partner, or let me just say that, it's just a way say that when one person has more than one multiple sexual partner, even though there's this particular translation people give that, okay, maybe in the last 6 months you've had more than 2 people, but I was even surprised to hear something different just about last week when I was told that it's possible for you to be in a relationship before, then you had sex, you broke up, then eventually you got married, and then you're now with your partner. But regardless of whether you are now faithful to this partner, you still have multiple sexual partner.
Come again, sorry.
In a lifetime.
Let me get this. Let me get this clearly. You had a girlfriend.
Yes.
You had sexual intercourse.
Yes.
You broke up with your girlfriend.
Yes.
And then you entered another faithful relationship.
Yes.
And then you got married. And then you are now with your new partner. Then you now said such a person is
still has multiple sexual partner.
Interesting.
To have more than one person in your lifetime. That's
maybe pastors are correct when they say that if you are in a relationship, you should just stay clean. Because I mean, you never can tell what will work or what will not work.
Exactly.
So, but if a person has had sexual relationship with someone before, and then person has another sexual relationship with another person has multiple sexual partners. It's not just the person who is saying Shalewa, Shewa, and Shayomi at the same time. All right, that's interesting.
All right.
Interesting.
Then the third one, mode of prevention is using protection. The C could stand for condom, in the sense that if you know that, okay, you're not sure of your partner's status, or the partner him or herself is sleeping around in quotes or has more sexual partners, just try and ensure you protect yourself. And the use of condoms is one of the very effective ways of protecting one from not just HIV, there are also other sexually transmitted infections that can prevent can be serve as a means of protecting oneself: hepatitis B, gonorrhea, syphilis, and the likes. So these are the three main methods of protection from.
Thank you for that input. And I think I also want to talk about the fact that I haven't tested positive, and I think that that is where we need to realize that our viewers, you need to realize that your healthcare providers are with you all the way. Even if you have tested positive, I would still appreciate input from Dr. Lorenshola on this regard, particularly as regards antiretroviral therapy. But even if you have tested positive, that is not the end of life. And I'm saying that as someone who has considered the propensity or the probability of that. You know, while I had my needle stick exposure, one of the things on my mind was, if this thing happens to, if I get a repeat test and it happens to be positive, what is the way forward? That was one of the things I did then. And, you know, I had to go back to, as if I didn't know anyways, I had to go back to those books again. And then I read and read and read about HIV. And I'm saying that HIV is no longer a death sentence. HIV is no longer a death sentence. And I like to compare it with diabetes and hypertension to paint a vivid visual scenario. Patients with diabetes have to use drugs virtually on daily basis to keep their blood sugar level in check. Patients with hypertension have to use their drugs on daily basis to keep their blood pressure in normal values. The same way HIV patients need to use their drugs on daily basis to prevent progression to AIDS, And there's a lot of improvements. There's a lot of knowledge base in science to the fact that an HIV positive patient can live a normal life. A normal life. I've attended to a patient before who had been diabetic for more than going to 15 years. And if you meet this woman, she's as healthy as whatever you want to call it. She sticks to her nutritionist regimen. She uses her medications. She checks her values time in, time out. And I think the same thing is also possible with HIV.
patients.
We have a lot of people who are living several years with HIV, and they are living healthy, normal lives.
Yes.
They're living healthy, normal lives. So I just want to say that if you have tested positive, first thing first, don't be like my patients. Try and seek help.
Yes.
And seeking help means starting your antiretrovirals early and being regular with them, going to your clinic, and for all we care, the drugs are free. Well, Dr. Famadi will probably still talk about this issue, this saga, these constraints that we're having now regarding this pullout that US recently did with HIV. But I want Dr. Olorenshola to talk about antiretroviral therapies. What does it look like taking those drugs? Do they come at a cost? And I mean, what are they about?
The antiretroviral therapy, just like the PEP, there are also medications that help people who are already positive with HIV to control, number one, the rate of progression, and also to help them to decrease the viral level. So that is one of the advantages. Like Dr. Omoleke had already said, that is important as people who are living with HIV to adhere to their medications. Okay, not only does it decrease the chances of it progressing to complications and all of that, it reduces the chances of transmission, the risk of transmission. I want you to know that HIV can be in a person's system, and the person could have sexual intercourse, could give birth to children, could breastfeed, and not transmit the infection to the receiving party. And that is in a case whereby they have used their medications, the antiretroviral therapy, to a level so well that it has reduced the virus, the load of the virus in their body, to an undetectable or minimally detectable level. You understand? So it is very possible to live an average, no, not even an average, normal life. There are people who are living with HIV and have a regular life expectancy. Yes. So it's very important, and I think that it's very important that I would like to commend you for reaching out to your sister concerning what happened to you, because there are the dangers of non-disclosure of one's status. First of all, if in a relationship, if you do not disclose your status to a person, let's say you're not even married, I'm talking about that marriage one. But if you're not married and you don't disclose your status, number one, you are liable to persecution by the law. So you could be persecuted for endangerment, even if you did not transmit the infection to the person. But because you put the person at risk and you knew your status, that is fraud. A marriage, it's a criminal offense. A marriage could also be termed invalid too. Yes, if the status of the party who maybe was positive was not properly, was not disclosed, right, to the other party, and so you can be, it's the marriage is invalid because there was no truth in it. You understand? So the truth is absolute. It is not relative. It is either yes or no.
Sorry for interrupting you, Dr. Lorenshola, and I think this is this is a time to probably commend religious leaders, settings that enforce and ensure premarital testing.
Yes.
Premarital testing. And I think it's
So
very important. It does a lot of good. It does a lot of benefits. I've had a patient a woman, she came to the clinic, sometimes, and I think our patients, people, the masses, everybody needs to hear this, that sometimes there's some information that your healthcare providers know that they cannot necessarily divulge because of the oath we've taken. The woman came to the clinic and she came for treatment, she came for testing. She said she came with her husband and that the husband also has a complaint. She came for antenatal clinic visit. So she said her husband also came to just wants to check his blood pressure. So the man insisted that he wanted to see me in the absence of, he wants his wife to excuse us from the clinic. Personally, as a doctor, I usually appreciate it when husband and wife comes to clinic together. So, but because he said he wanted to be seen without, in the absence of his wife, the wife had to excuse us. And then when I called him in, and then he had to start telling me that he was actually positive for HIV, and he has been out of clinic for about 6 months. I asked him a question. I said, "Have you been having sexual intercourse with your wife?" He said, "Yes." I said, "Is she aware that you're positive?" "No." "When was the last time you did your viral load?" "You can't remember." "Have you done other investigations?" I felt so pain for this woman. When I called her in, I had to ask her that, "Are you aware of any medication that your husband uses from time to time?" She said, "Not particularly. He just uses one supplement." At that point, I felt so irritated. I felt like
this just unfair.
Just so unfair. And at that point, I was bothered. This woman is so much at risk. She's pregnant. Yeah, we've done our booking investigations. As at that time, she was negative. But I mean, why would you be positive? You're not on drugs. You are not checking your values. You don't know your viral load. You don't know your CD4 count. You keep on having sex with this woman. If she says she wants to deny you, you claim this husband quote and unquote superiority. And I mean, I think people really need to hear this. And well, we're not stigmatizing. I'm just saying that it's important, like Dr. Lorenshola said, that people should open up, disclose your status to your partner.
Yes.
I think I'm learning the fact that it's actually the marriage will be rendered invalid if a person does not disclose their status. And I think people need to know that. I need to know that.
Yes. So I there's also some in the case of this patient, there are some crimes whereby there are medical legal policies already, whereby if there is a partner who is at risk, whose health is at risk, right, and they are not in the place whereby, or they do not have the information that they need to make a well-informed decision about their health, the government, right, or social organizations can actually stand in gap for the person. So you as a doctor may not be able to divulge the information, disclose the information for the sake of confidentiality, But you can, yes, it might not come directly from you, but that is why I said it's medical legal. The government has to be informed about it. The law has to be brought in. So there are some crimes whereby the party who is positive would be persuaded to open up and to tell their party, the other party, their partner, that this is my situation, this is how long I've been, and all of that, and then they make their health decisions, right? Well, but if the person is still stalling after a while, and then we can now step in. So in that situation, we have some laws like that, some organizations that do that. Even the social welfare as well too can, yes, it's social and welfare. They can come in and attend to all of that. So because we cannot just be looking at her suffering now. We can't just look at her being at risk of being jammed by a trailer or hit by a trailer and we leave her there on the highway because she feels like there's nobody, there's nothing happening around. You understand? So I think that's also that's one of the beauty of the progressiveness of the society right now. I'll also, okay.
All right. There was something that dropped in my mind while you were speaking. I'll still allow Dr. Family to talk about this U.S. Withdrawal of their support or their donations and how it's affecting or what level of impact it will likely have on HIV care and availability of drugs in Nigeria particularly. But there's something I want to talk about. I remember a patient I saw in the clinic some weeks ago. The patient came, said he had been to 2 different hospitals, presented with symptoms they thought was malaria. They managed the patient for malaria. Patient, according to the patient, the first place they didn't even do a testing, and the second place did the testing. They managed the patient. Patient was stooling, had fever, had rigor, all kinds of constitutional symptoms. And then I made a request that patient should get serology screening, and then patient happened to be HIV positive. When I saw the results, as a doctor, I was already adjusting my seat and trying to recall all of this GADA acronym that we use for counseling. Greet, ask, tell, help, make a decision, and all of that. I was already thinking about what the reaction of the patient would be to this news, breaking bad news, all those things what we learn from psychiatry. Only to approach the patient, and I told the patient that, have you done a screening for HIV before? The patient said no. I said, well, unfortunately, the screening that you did came out positive. At that point, I paused. I was hoping to get a response and then to know how to empathize with the patient and then counsel them. And I was surprised that the patient actually thought HIV was just like
malaria.
Was just like malaria. The patient just asked me that, hope there's drug that I will take and I will use and I'll be fine. I had to come back again and said, what I said is that you are HIV positive. Do you know HIV? Then he said, is it not one infection like that? I said, it's an infection. You're correct. I said, have you heard about it before? The person said, I hope I shall get drug and I would be treated. At that point, I was shocked to realize that there are some part of our society that do not even know that HIV is actually, that do not even know anything about HIV. And the funny thing? The funny thing about this patient is that this patient is about, if I'm not mistaken, para 8. If I'm not mistaken, para 8. Meaning that, now I will not be calling this out, but this patient comes from a tribe in Nigeria where polygamy is the order of the day.
Okay.
Meaning that the husband likely has about 6, 7, 8 wives. Now, imagine that she had been positive for a while. Imagine that she had transmitted the virus to her children. Imagine that her husband, she got the infection from her husband, or she had infected her husband. And the husband had infected other wives.
Who could have been pregnant.
Have given birth, have children. That just tells us about what our society really looks like. Nobody should think that HIV is not a problem in Nigeria. It's a big problem. And now, especially with regard of this US withdrawal thing. I don't know if you want to make a comment on that.
All right. So based on that, it was a real shock to the world when the US, the president, decided that they were going to opt out from the USAID. And this was, the impact is not, I would say it's particularly being felt significantly for now because of the support that Nigeria has received over a while. So we still have some drugs in stock. But to get to a point whereby we may have to start looking for donors. So currently, the US is experiencing what we call donor fatigue syndrome. These people have been donating for a while.
I think you should break that down. Break that
So
down.
what it implies that for organizations like the US, let's say high income countries, over a period of time have been donating significantly to low and medium income countries to support them in several areas, including health, whereby they've been donating so much to ensure that we are able to get rid of the infectious diseases or put them to a particular level that is not significant. HIV is one of them, even malaria and every other diseases. But because of these funding cuts, and even the withdrawal from the WHO, not just the USAID. So over time, we may start seeing the impact by patients who might have to start buying their medications. Currently, the medications are being given for free. And this comes at a huge cost that are being incurred by the high-income countries. But now that we don't have that anymore, so the question that we now have is, so who would who would step in and ensure that these drugs will be readily available to the public? So what are we supposed to do? What should be the response of our government to this problem?
And I think this is where I need to beg whoever is listening to us right now that if you're not positive, stay negative.
Yeah.
Because you never can tell. The Nigerian government looks so much unprepared. It looks as if it will take quite a while. I want to be optimistic, in my conversations. So, but the Nigerian government seems to still be crawling in taking up their responsibilities as regards management of chronic diseases. And I think it's important that whoever is negative should stay negative. Practice abstinence, practice safe sex, and as much as possible, like Dr. Famadi has said, abstinence, be faithful, and then use protection, use condoms. And if you are positive, it's not a death sentence. You can live a normal life like every other person. Just to ensure that you stick to your clinic visits, you check your values, your viral load, your CD4 count, and that you use your drugs, your ACTs, your highly active antiretroviral therapies on daily basis. So I don't know.
So in addition to what Dr. Moleke the Great has said, so in addition to being negative and remaining negative, and if you're positive, you can actually have a positive outlook on life, really, that it's not a death sentence. I'll just like to add that aside the sexual means or routes of transmission of HIV, please avoid sharing sharp objects. If you're going to be receiving blood from a facility, right, a healthcare facility, ensure that it is a proper healthcare facility you're receiving blood from, and it is well screened, thoroughly screened blood that you're receiving. Avoid sharing of sharp objects, clippers, nail cutters, whatever can lead to any open wounds or injuries.
All right, so my take-home note will be to people generally regarding, if in case you're aware of someone who is HIV positive, please do not stigmatize. They are also human beings like you, like every one of us, and they deserve all the care in the world. So it's best you step in by supporting them emotionally, even financially, to let them know that they're not alone in this journey, but by doing everything possible, taking their medications, they will get well. And that will go a long way in ensuring that they are adhering to their medications. But when people also take medication, they don't want people to know that they are on drugs. So please be supportive and not stigmatize. Let the love spread around. All right.
Yeah, so thank you so much for your time. My own ending note or my ending words would be that if you're negative, please stay negative. If you're positive, please seek help on time. There's help available.
Yes.
Massive help, as I would like to call it. There are all manner of organizations, institutions, non-governmentals, and so on and so forth, ready to support you. And like your public health doctors that we are always with you on the journey. Always with you on the journey. And till we meet next time, I remain Omoleke Akintunde. And I want to please specially thank my learned colleagues, Dr. Faramade, Dr. Lauren Shola. Thanks so much for the time. And shout out to Mindset Studio where this was done. Thank you so much. Till we meet next. Ensure you like, share, and subscribe.